Alright, we're going to go ahead and get started. Welcome to Grand Rounds. Today, our guest lecturer with us is Dr. Silva. She comes from Tulsa, Oklahoma. She is an adolescent and pediatric gynecologist. Comes the way of Albany Medical College, did residency at Parkland, and then a fellowship in Baylor, Texas Children's. She's published quite a few papers on adolescents, gynecological issues, and even consulted a couple of books and chapters as well, I believe I saw. So she's here to talk to us about abnormal uterine bleeding in the adolescent pediatric population.
Thank you. Can you guys hear me? Yes. So my name's Rupa de Silva. I'm super easy. Like if you guys have questions, please stop me and ask, But I really wanted to spend some time today talking about abnormal uterine bleeding in the adolescent. I threatened Priya with talking about her for about an hour and giving you guys stories of how our family has a OB curse in it. But she strongly dissuaded me, and they only gave me an hour, so I thought I would just really stick to the medicine of the whole thing. But so abnormal uterine bleeding, is it the same in the adolescent or the adult? And I really wanted to take some time today to talk about what the differences are. So that's really the objective of the talk. I have no disclosures, but I thought we'd start and frame the whole lecture in the form of a case. So you have a 12-year-old female. She presents to the emergency room. She just fainted or nearly fainted in the bathroom. She states that after school today, she was kind of nauseous and dizzy, and she fell to her knees. She was brought to the hospital immediately. She's conscious, and she reports some intermittent, crampy abdominal pain. She denies nausea or vomiting, has good appetite, no urination problems, has normal bowel movement this morning. You start asking about her gynecological history. You learn that she started bleeding 10 days ago. The first 2 days were just a little bit of spotting, and then the last 8 days she's really been changing her pads quite regularly. States that since her period started, she's been increasingly tired and dizzy, and sometimes she even gets dizzy when she gets up too fast. Okay, so GYN history, she's had menarche this year. She uses pads, not tampons, says she's not sexually active. Mom says she has always had heavy periods, had a hysterectomy at age 42. Dad says he bruises pretty easily, but not really, no bleeding disorders in the family. She's not pregnant. Her hemoglobin's 7, and an ultrasound was done, which is normal. 7 weeks uterus. Her endometrial stripe 6 millimeters, normal ovaries. Okay, so I thought we would start by talking about what is normal in an adolescent. So obviously that case is a situation that is probably not a normal bleeding for anyone. But in an adolescent, the norm is actually anovulation in the first year. So periods are not normal, and they're not expected to be normal because of the immaturity of the HPO axis. And so menarche is 12.43, so 12 and a half basically, and it has not changed over the years. Despite the discussions about hormones and puberty and whether that's changing or not, the age of menarche has not changed. Mean cycle interval, so traditionally we're taught 28 days is our mean cycle interval, but in adolescence it's about 32 days in the first year with a range of 21 to 45. Periods should be less than 7 days long, and usually 3 to 6 pads is the average. Now, so the interesting thing about that is when you ask an adolescent patient, okay, so I have never met an adolescent patient. I say, hey, do you have heavy period? Are your periods heavy? And every single one of them, 100%, says yes. And so, I mean, I've never met one. And so one day I started asking them, I'm like, hey, so, how many pads do you use in a typical day? And one of my patients said 2. And I said, okay, well, that's not so heavy, that's not so bad. Why do you consider that heavy? And she said, well, it's heavier than when I didn't have periods. So for adolescents, it's really a frame of reference and where they're coming from. Because for them, everything is heavy because they don't really want to have periods. They're really new at this whole thing. And so how we ask them the questions and how we get the information in adolescents is very different than in adults who are more used to having periods. So in an adolescent, okay, so just like we talked about, perceived measurement can be highly variable, but probably abnormal if they're bleeding for more than 7 days and they're changing their pads more than every 1 to 2 hours. And sometimes I'll ask them, how many pads are you changing? And and so we have to kind of think through, like at school, how many pads they're changing. We have to help them with that concept because it's kind of a new concept for them. And they'll say, I'm changing it every hour. And I'll ask them, are you changing 24 pads in a day? And they'll be like, no, I'm changing like 6. So you just, where they're coming from and how, you want to be as specific as possible with them. But common causes of heavy bleeding in an adolescent: anovulation, a bleeding disorder, endocrine problems like thyroid or PCOS. There's some medicines that you can, I forgot how the pointer works on here, but there's some medicines that you can, that could cause it, and less commonly are things like foreign body malignancy and stuff like that. But the thing I want you to notice on here that's different, there's no fibroids are not a common reason, adenomyosis is not a common reason, polyps, those kind of things are not common reasons in adolescents. Anovulation is the #1 cause, and bleeding disorders are #2, so we really need to think about those in adolescents. That's different than adults. So we talked about this. For heavy bleeding in an adolescent, longer than 7 days, greater than 80 milliliters per cycle, and that's what all the books say. And it's kind of one of those things like, who is getting out their Bunsen burner and their graduated cylinder and trying to figure out what 80 milliliters is, especially in an adolescent. So I'm going to talk to you about ways that we might be able to quantify that a little bit better for our adolescents. Soaking more than 1 pad or tampon an hour is not normal. Passing clots that are more than 1 inch in diameter. So that's a decent size, and so you want to ask them if they have clots and what size they are, quarter size, dime size, etc. And then there's something called a PBAC score, and it's a pictorial blood assessment chart that's now been verified and is now a new method for standardizing our blood loss. Now it's pretty new. It looks like this, and you can give it to the adolescent and they are supposed to fill it out on a month-by-month basis. And it has been validated. It's been validated in adults. But the newest data in adolescents seems to think that it is equally valid in adolescents. And the bottom line is you get a point, or 5 points or whatever for how heavy and how full your pads or tampons are. You get some points for clots, you get a point for flooding, and then you add up the score and for the month. And so greater than 100 is highly indicative of heavy menstrual bleeding. And so that's sort of the newer trend on how we get our adolescents to kind of really quantify so we can be a little more objective in our thought process of whether their bleeding is heavy or not. So, okay, so we've determined how we figure out if they are, but let's talk about the workup, okay? So in an adolescent, how are we different? Well, we don't always have to have a pelvic exam. In fact, most of the time, you probably don't need a pelvic exam. And in adolescents, it's very common and okay to just do an ultrasound. So if there's some concern about a structural abnormality or something like that, you may need to do a pelvic exam. Or if you're worried about a hymeneal problem or an imperfect hymen, perhaps an external exam is warranted. But most of the time, if they're having heavy bleeding, like something's working, it's coming out, you know what I mean? So if we get an ultrasound, that will give us, probably the same amount of information as a bimanual exam would do in an adult. So evaluate for hemodynamic stability and get their CBC. Of course, we always have to rule out pregnancy. That goes without saying. We're going to screen for anemia, and then we're going to evaluate for bleeding disorders. So I'm going to talk to you a little bit about that. So now, if they're sexually active, our case and our patient was not sexually active, but if they are, does the exam change? Not really. They still don't necessarily need a pelvic exam to work up their heavy vaginal bleeding. Of course, we're going to rule out pregnancy. And the big difference is you want to just rule out STIs, sexually transmitted infections. But otherwise, you don't necessarily have to do a pelvic exam. So different than an adult. So workup. Okay, so again, anovulation is the norm. Okay, so we want to remember that, heavy menstrual bleeding usually is just because of anovulation. It's still heavy and we still need to treat it, but it doesn't have an anatomic cause. It can present at menarche, and we want to remember hematologic stuff. So von Willebrand's disease is the #1 hematologic disorder that you might find in an adolescent with heavy vaginal bleeding. It's 1% of the general population. Now the interesting thing though is in adolescents who present to the emergency room with heavy vaginal bleeding or menorrhagia, 1 in 6 girls is going to have von Willebrand's disease. That's a decent number. So we need to remember that all these patients that come into the emergency room probably needs a workup for platelet dysfunction and von Willebrand's, all these adolescents. And James et al. Went on to say that 36 to 44%, so like a third of our patients that have heavy bleeding, the ones that come into our clinics, the ones that come into our ER, et cetera, a third of them are going to have some sort of platelet dysfunction or von Willebrand's. So we really need to really need to evaluate that in our adolescents who come in with bleeding. We always want to consider consultation with hematology oncology, especially when they're in the hospital. If they're bleeding that much, we might need our colleagues to get involved. So again, we've talked about the screening tools and what things might make us think about von Willebrand's or a platelets dysfunction, and I've gone over this already. But family, heavy bleeding, of course. If we're treating them for anemia, so we're admitting them in the hospital, giving them blood and dealing with their bleeding. Family history, and excessive bleeding with surgical procedures, okay? And so with this, when you have a P-back of greater than 100, you have a really good sensitivity for detecting a bleeding disorder. So just, I don't mean to keep saying that, but just please don't forget to check for bleeding disorders in this population. Like we said, and I give you this slide really just to remind you of the 3 types of von Willebrand's. There's type 1 and 3, right, which there's not enough von Willebrand factor or there's none. And then type 2 means that the quality of our von Willebrand factor is not so good. And I'll talk about that in just a second. So how do we screen for these bleeding disorders? This should say screen for von Willebrand's and platelet dysfunction. But this is what ACOG says, or the American College of OBGYN. Okay, we need to do a CBC and some coagulation panel. We need to do fibrinogen and thrombin clot time. And we need to check for our von Willebrand antigen level and our ristocetin cofactor and factor VIII activity. Now, if any of this testing is abnormal, we want to do further testing. And so the ristocetin cofactor activity really is the confirmatory test for the von Willebrand's, and you want to do von Willebrand multimers for subtyping. Is it type 1, type 2, type 3? So the thing about testing for these things is that they're a little bit finicky. Okay, so you want to try and perform them in the first few days of the period. You want to do it before the patient gets any blood products if they're in the hospital. It's probably okay if they're on birth control pills, but any acute phase reactant can mess up the von Willebrand's panel. So test often and at different times. So you're going to test them when they first come into the hospital, and if it's normal though, don't test again when they've been, when they're in the clinic setting in 3 or 6 weeks or 12 weeks when they come back to you, because they're not always accurate in the acute setting. And also, based on where we are on our cycle, rising estradiol levels may mask the disease. So you want to keep testing and test often. Now, if things are not right, and you're like, man, she really is acting like she may have some sort of bleeding dysfunction, and the von Willebrand testing is not right, there is a test called PFA 100, which is a fairly new test, and it tests for platelet function activity. And so you can test for that, and it's a little more sensitive than the von Willebrand testing. But again, if we're at this point, you might want to involve your hematology oncology and see if, what thoughts they have up their sleeve. Okay, so then I thought we would spend the rest of our time talking about how to treat heavy bleeding. We're going to talk about it in the acute setting, and then in the non-acute setting, like in our clinic, and then we'll talk about also long-acting reversible contraception and where that falls into the whole thing for adolescents. So, okay, so treatment for the heavy vaginal bleeding. This is my disclaimer slide, which basically says most of the data that we use in adolescents, nobody likes to study adolescents, so we usually study adults. So most of this, the adolescent data is extrapolated from adult data, but the thought is that the physiologic mechanisms should work the same. Okay, so estrogen. We're going to talk about estrogen use first. Now, don't forget, whenever you have an adolescent, you have a lot of people in the room, right? You have an adolescent, you have their guardian, and then you have our adolescent attitude, right? So the 3 of those together, have to help have to be involved in the decision making. And we need to, when we talk to our adolescents, we really need to think about how we're going to set them up with a treatment regimen that sets them up for success. Some people are good at taking pills, some people are not good at taking pills, et cetera, et cetera. How involved the guardian is, how much support the adolescent has, and all of those kind of factors. So the traditional thing that we've always done for heavy vaginal bleeding is estrogen. Okay, and so let me tell you how that started and the goods and the bads about it. So in the 80s, DeVore looked at estrogen, IV estrogen, 25 milligrams, and he gave it at, 0, 3, and 5 hours. And in 72% of women, the bleeding stopped. The acute vaginal bleeding stopped versus 38% with the normal saline. And so that began the treatment for IV estrogen. So in further studies, really we've determined that in 48 hours, most acute menorrhagia will stop with IV estrogen. And how does it do that? It promotes the regeneration of the endometrium, and it increases our coagulation factors, our von Willebrand factor that we were just talking about, and factor VIII, and it promotes platelet aggregation. And that's how estrogen stops the bleeding. Okay? So that works. We know that works. And then eventually, in our 48 hours, the bleeding stops. We all know that we have to add progesterone back. We can't just keep them on estrogen forever. And so we've always traditionally gone over to a high-dose OCP taper. Okay? And so in traditional studies, so in the 80s and the 70s, they always went to higher dose pills. And so the data shows that IV estrogen should be equal or comparable to a 50 microgram estrogen pill. Okay? Like a 50 microgram, estradiol pill. And so, and then we taper them. Now the difference in adolescents, so we always, there are millions of tapers out there, you guys have heard them all. Many people do like 4 pills for 4 days, 3 pills for 3 days, 2 pills for 2 days, and they go to 1 pill, and do not take the placebo pills until, so you guys, and for the pediatricians in the room, you may have heard that. In adolescents, we actually do the taper much slower than that because their hormone levels are much higher. They're the highest they're going to be in their whole life, right? So because they're going through puberty. And so in adolescents, the taper is often 4 pills for 4 days, 3 pills for 3 days, and then we'll do 2 pills for 2 weeks. So that's the difference between the taper is slower so that we can stabilize their endometrium longer. Also, adolescents, we're setting them up for success, right? They're not going to be some are really good at taking pills and some are not so good at taking pills. And so perhaps they're not so good at taking pills. And so at least, even if I ask them to take them twice a day, they'll at least get it in once a day. So we in our ability to control that bleeding over long term is better with the slower taper. And now more recently, we have talked about doing tapers with lower dose pills, not the 50 microgram, but more like the 30 microgram pills. And so you'll hear about a similar taper, 4, 3, 2, 1, or 4, 3, 2, and for 2 weeks, but more with 30 microgram pills, and that's really your choice. Most pediatric adolescent gynecologists, when they're from the acute setting, will go to a 50 microgram pill and taper with that, but people are starting to do it with lower dose pills. Okay, and then in the acute setting, we should never forget our other agents that we have. So tranexamic acid has gotten a lot of play because in the last few years it has gotten approved in the States. It is an antifibrinolytic, so it prevents the lysis of fibrin, so it promotes clotting, and it can be used with or without estrogen or birth control pills to help decrease bleeding. Okay, and so in the acute setting, often we'll use this to stop the bleeding. Before the tranexamic acid came, we had aminocaproic acid, which we used a lot in the hospital, and as we didn't really use it as outpatient, but there's a PO form of it. But it is considered less potent and has more side effects, so really tranexamic acid has taken over that. And then of course there is DDAVP, which is an analog of vasopressin, and even if you don't have a diagnosis of von Willebrand's, this can be used for, to decrease bleeding in those situations where, you know, estrogen may just not be enough, or you need a little extra to get the bleeding stopped. Okay, so I talked to you about tranexamic acid and its role, and really it inhibits the plasmin activator, and so it prevents fibrin from being broken down. Okay, so this just is exactly what I just said. This is the doses that you can use it in, and that you can use it with or without estrogen. It's very common in girls who don't accept hormones, or because of whatever values are going on, or for whatever reason. We use this a lot to prevent acute bleeding. Now, so in the acute setting, you know, there are definitely times when estrogen is not okay. So we just talked about how we have our tranexamic acid, but we also have progesterone. So, you know, the World Health Organization has lots of contraindications, and, you know, for those of you who may not be as familiar, you know, with those, clotting disorders and DVTs are the most common reason that you can't use estrogen. But, you know, there are other things that we kind of don't think about as often. Diabetes with vascular complications, migraine with aura, chronic hypertension or hyperlipidemia are what they call category 3, which means generally we shouldn't use them, though you could probably make an exception. And then there's relative contraindications, like we don't really love using estrogen in cancer patients, or if they've been immobile for a long time. And so in those patients in the acute setting, we have to remember that we have progesterone options. So in the acute setting, so what happened in the 80s is that they started using estrogen and progesterone, which is the 5 milligrams of norethindrone acetate. Okay, and they noticed that the bleeding got better. And then they got a little braver in the 90s, and they started using progesterone-only regimens. Okay, and here they started using medroxyprogesterone acetate, which is Provera. Okay, and they used it for multiple days, and bleeding stopped within 4 days. So again, that's not as fast as the 48 hours that we have with the estrogen. So we traditionally like to use estrogen when we have in the acute setting with bleeding because it's faster. But for those people who are not great estrogen candidates, or for whatever reason don't want estrogen, we have to remember that we have progesterone, and our bleeding will stop. It takes a little longer, but it will stop. And so more recently, the regimens that are most studied in the acute setting are 20 milligrams 3 times a day of medroxyprogesterone acetate for 7 days, and then long term, you can use it once a day for 21 days. And then some people will do the medroxyprogesterone acetate for 3 days, and then plus a dose of Depo-Provera, the shot. And just to allow, and that has improved compliance for those people for those patients who may not be so good at taking progesterone. And so we have different regimens, and I just wanted you guys to have these regimens. I think you guys are going to get this PowerPoint through Ginny, and so that way you have some regimen options in your armamentarium. But more recently, they talked about a taper and how we taper the progesterone. And so really they talked about 10 milligrams every 4 hours, and then every 6 hours for 4 days, every 8 hours for 3 days, and then twice a day for 2 days to 2 weeks. Like we talked about, in adolescence we like slower tapers. And so with these slower tapers, we often go for 2 weeks at twice a day. Okay, so in the non-acute setting, let's talk about estrogen versus progesterone, because eventually our patients get out of the acute setting, and we need to talk about long-term maintenance of these patients. So estrogen use. Okay, so we have traditional estrogen use. We talked about our taper, we have our patch and our ring, okay? And so they looked at the data of whether adolescents use the ring or the patch and whether compliance is better than the pill because, you know, it's a little bit easier to remember, and really the compliance is the same. So it's really what the patient feels comfortable with and what the families feel comfortable with, and, you know, whether you want to taper it or not, okay? But if the pills, which are most studied, right, and when they're tapered, are the most effective at producing amenorrhea in a continuous fashion, okay? So the advantages, so let's just talk about using the pill. Since the patch and the ring work the same, we're going to talk about it in the frame of reference of frame of reference of the pill. So directions are simple. You just take a pill once a day. The estrogen does increase the amount of von Willebrand factor and factor VIII in the bloodstream, which we know helps decrease bleeding. There is no effect on bones because, you know, people worry about that with some of the progesterone options. There's a good return to fertility. And if you use it in a combined fashion or a long-term fashion, you will have decreased bleeding. The disadvantages. People forget. If you use it in a continuous fashion, or you suggest that adolescent have a period once every 3 months, then there's a lot of breakthrough bleeding. And adolescents have a lot more hormones than adults. And so there's a higher risk of breakthrough bleeding, especially when they're not as anal about taking it at the same time every day and whatnot. And so if they have bleeding, even if it's just spotting, adolescents won't take their pill. So that makes it harder to get them to have good compliance and control their heavy vaginal bleeding, and then they'll stop taking them, and then you're back where you were. So traditionally we have said, okay, let's take a pill, so you skip the placebo pills and you have a period once every 3 months. Now, if that's hard for an adolescent or they continue to have breakthrough bleeding, you can do it so they have a period once every 6 weeks instead of every 12 weeks, or once every 8 weeks, and slowly build up to every 12 weeks in an adolescent so that the compliance is better and they don't have so much breakthrough bleeding. And this is, again, I just wanted to put some regimens. We've already talked about this. I wanted to put some regimens in your slide set of how we do outpatient management. And here's another algorithm for you guys. But the point of this algorithm really is, you know, all the algorithms in adults, we talk about, you know, one of our algorithms is really to go towards surgery. If their bleeding is not controlled with medical management, we consider surgery for them. But in adolescents, that's a no-go. So D&Cs are very much a last resort. Obviously endometrial ablations and hysterectomies are very much a last resort because we want to preserve fertility. But even D&Cs, which is very commonly done in adult women, is a very rare instance in an adolescent. In the outpatient setting, for those patients who don't want estrogen or who need a little more than just the traditional pill or patch or ring, we can use our tranexamic acid. So our oral dose, this is here, it's 650 milligrams, and it's 2 pills TID for up to 5 days. So tranexamic acid has a theoretical risk of thrombosis when you're using them with hormonal contraception. So, however, it's a theoretical risk, and it is still used commonly, and it does work. Now, let's talk about progestins. Now, this is long-term use of progesterones, right? So this does avoid your thrombotic risks that you have with estrogen and combined oral contraceptives. And it avoids the stigma of contraceptive use for those families or patients who are not interested in estrogen-containing pills or hormones. So in the acute setting, they use medroxyprogesterone acetate in all the studies. In the long-term settings, if we're going to control her bleeding for long periods of time, the studies use agestin, which is norethindrone acetate. And I don't know why in a long-term the studies only use, or most of the studies use norethindrone acetate versus in the acute setting the studies only use medroxyprogesterone. But there's not studies that talk about norethindrone acetate, about medroxyprogesterone. There are studies, but most of them are done with norethindrone acetate. So that's why I'm going to show you the data on norethindrone acetate. It does not mean they couldn't be reversible or exchanged or anything like that. So norethindrone acetate is, you can use 5 milligrams or up to 50 milligrams a day. And you have some androgenic side effects like acne and moodiness and breast tenderness, hair growth, headache, and dysmenorrhea. There's a theoretical risk of thromboembolism, but it is considered safe to use in patients who do not have estrogen. And this is really the preferred progesterone pill that we use for long-term maintenance of heavy bleeding. Okay, it's metabolized to an ethinyl estradiol, and if you use it for long periods of time, you can get decidual cast formation, and that can cause pain due to decidualization of the endometrium. You can also, there's a few case reports of getting hepatic adenomas when you use these for long periods of time, like multiple years, but very rare, and something that you may need to keep in the back of your mind, but not a reason to not start patients on that. ACOG, our American College of OBGYN, says that for special populations, progesterone is the treatment of choice for heavy vaginal bleeding over estrogen. For instance, our patients with developmental delay or those undergoing long-term cancer treatment. Remember I told you there's that theoretical risk of how we don't really like to use estrogen in our patients with cancer. So we want to think about using progesterones in these cases. And so again, the treatment would be norethindrone acetate, 5 milligrams a day for extended periods of time. If people who aren't so good at taking the pill, you can use the Depo-Provera shot, or you can use long-acting reversible contraceptives like the IUD or what we traditionally call the Nexplanon, the etonogestrel subdermal implant. These obviously provide contraception, but they are longer term and will promote compliance. So let's talk for a little bit about the shot. So how does it work? It inhibits ovulation and it decidualizes the endometrium. So 50 to 75% of girls have amenorrhea in a year. So from a heavy vaginal bleeding point of view, it's a reasonable option. However, they have irregular bleeding for 3 to 6 months, and you need to set them up for that and make them aware of that. Now, for those people who have the initial irregular bleeding, you can give the Depo at shorter intervals so that you can have more rapid suppression. And that will help for those girls who have heavy vaginal bleeding, for that bleeding to stop sooner. But adolescents, they just need to know what the risks are, and what the side effects are, and they will tolerate them. But it's all about how you counsel them. If you tell them that you're going to have weird bleeding and spotting for 3 to 6 months, and you're just like, we'll help you deal with it, but you're going to have to deal with it, and then it'll get better, they will deal with it. They just need to be aware of it. And so it's all in the counseling of an adolescent and their family, in their ability to tolerate the side effects. So just let them know that they're going to have that. And from a compliance point of view, this is going to be better than taking a pill for anybody, adult, adolescent. All the data shows that if we don't have to think about taking it, it's going to be easier. So pros and cons, okay? So you take personal error out of the equation, so that's going to improve your effectiveness. And you have a long-term improvement of abnormal vaginal bleeding. The cons, you do have that increased risk for breakthrough bleeding, but again, you can give it to them for shorter intervals for more rapid suppression. And then the other con is they do have to show up every 12 weeks. And then the two biggest side effects that we always worry about with Depo is one is bone loss, but all the data, I think it was on the previous slide, shows that, if you do have a bone loss during the time you take Depo, but in adolescence, the return of bone loss is back to where it was before you ever took it once you stop taking the Depo-Provera. So weight gain is always a risk. The package insert says up to 15 pounds a year. Now the data now shows that Depo-Provera makes you hungry. And so if you eat more, you will gain weight. That's natural. If you eat the same, that's how some people don't gain weight. And so again, it's all about telling your adolescent that they are going to be hungry, and that they need to control what they eat, and that they are mentally prepared for that. the studies show that that has helped decrease the weight issues with adolescents. So if they know they're going to be hungry and that they need to eat carrots instead of Doritos, well, because the natural instinct, at least for me, is to eat Doritos, then they will eat carrots because they don't want to gain weight and they also want their bleeding to stop, but they just need to be aware of those issues. So the other option that you have, if you have someone who takes Depo-Provera and they have a lot of spotting, they don't really want to take the shot earlier, every 4 to 6 weeks, you can add estrogen add-back, like a small dose of hormone replacement estrogen in either a pill or a patch form, so of estradiol, it will decrease bleeding and stabilize the endometrium so that they don't have as much of the irregular bleeding and don't have that side effect. So, and then once that 3 to 6 months are up, and you can try taking the estradiol off, and if their bleeding gets better, great. And if it doesn't, you just add the estradiol back on. And we've been very successful with adolescents in that respect, so that we can take away their biggest complaint, which is irregular bleeding, while still giving them the decreased bleeding effects of the Depo-Provera. So we talked about long-term options for long-term progesterone options for the use of heavy bleeding. So we talked about Depo, which lasts for up to 12 weeks. But let's talk about the long-acting reversible contraception and their use in heavy vaginal bleeding. And that is traditionally what we would call the implant, which lasts for 3 years, or the IUD, which there are 3 different kinds and can last for 3, 5, or 10 years. So our American College of OBGYN and the American Academy of Pediatrics now has said that long-term options may be the best option in sexually active adolescents with heavy vaginal bleeding, even in a patient who has not had children. And so FACOG started this first, and they talk about how basically long-acting reversible contraceptions, they're safe and they are effective for bleeding in our adolescents. And more recently, our American Academy of Pediatrics has come out and said that we should really be thinking about long-acting reversible contraception in our adolescents, and because they're effective, they're easy, and they're safe. So both academies are now on board with using these methods. And in fact, since then, the World Health Organization has also said for adolescents, we really should be talking about, when we talk about contraceptive options in the frame of heavy vaginal bleeding or even in the frame of contraception, we should be talking about long-acting reversible options first, and then go down to our shots, and then go down to our patch, ring, pills, versus traditionally where we say, hey, let's talk about the pill first, and then we go up as we go through the list. We really should start from the top and think about the long-acting first and go down when you're talking to adolescents. Because again, we're here to set them up for success. And so things that don't have compliance involved in it are going to set them up for success. So they did a study out of St. Louis called the Choice Project, and they took away all the cost barriers for all different types of contraception. And they said, hey, asked all adolescents, what would you use? And they chose LARC. You know, 2/3 of them chose to use either the IUD or the implant. And so the conclusion was that with proper counseling and when you take away the barriers, that adolescents even themselves are agreeable to long-acting reversible contraception. And so that's the reference. So then the question is, okay, do we use the implant or the IUD for heavy vaginal bleeding? Okay, so adolescents are okay with LARC. But when it comes to bleeding, there's going to be less satisfaction just in general, because progesterone options have 3 to 6 months of sort of irregular bleeding associated with them. And so you have to set adolescents up again for that success, okay? You need to tell them that, and they need to know that. Now, when it comes to bleeding, adolescents were happier with the IUD to decrease bleeding than the rod. And that makes sense. The IUD is studied to decrease heavy vaginal bleeding, and we'll talk about that. But there is good use for the rod, but there was more happiness with the IUD. Okay, so we're going to talk about the implant first. So it has etogestrel, that's always a tongue twister for me. It has 3 years. First 90 days, okay, 72% have no bleeding, but about the other 17% will have some bleeding or spotting. Okay, so then in the choice study, the 60% of implant users said they had lighter bleeding than before they were using the implant, when they were using nothing. And 65% of patients noticed decreased cramping. So a good percentage of them will have decreased bleeding with the rod, okay? 20% can achieve amenorrhea in adults, okay? And then the Nexplanon, if you look at the package insert, they do say that 11% request removal for irregular bleeding that they don't like. And so I tell my patients, I'm like, it's 1 in 10 approximately that decrease that. But again, in the implant removers, just like we use for Depo-Provera, we've had good success with adding the estrogen add back so that they don't have that spotting that they don't like. And so teens need to know that they have that in their options if they are in that 11% that have an unfavorable bleeding profile. And then let's talk about the levonorgestrel IUD and heavy bleeding. So that's traditionally what we call the Mirena, and that works for up to 5 years, okay? And this particular IUD is the most studied in decreasing heavy vaginal bleeding and cramping, and it is FDA approved for decreased bleeding, okay? It lasts for up to 5 years. It is, and 20% will experience ovulation suppression in the first year, and 50% will have amenorrhea in the first year. So 50% amenorrhea in the first year is not that different from the other progesterone options. But it has been shown to be superior to just using NSAIDs and tranexamic acid. It's superior to just using medroxyprogesterone. It's superior to using combined OCPs. And it's effective in women with bleeding disorders. And it's equally as effective as endometrial ablation while still having a good long-term acceptance. That's pretty powerful for heavy vaginal bleeding with a long-acting option. So if you can get an adolescent to be comfortable with putting an intrauterine device inside, then you have a good chance of helping them with their heavy vaginal bleeding. And so one last study, they talked about, this is a New England Journal, and they basically took 500 patients and they did this Menorrhagia Multi-Attribute Scale, MMAS. And it looked at all different factors in their life, and lower scores were worse, okay? And they followed these patients over 2 years. And you can see, this is my pointer, that again, lower scores are worse. So with the intrauterine system, the IUD, they had better bleeding profiles, okay? And their mean MMAS score was better. So the data shows that, the data is all in the Mirena, the levonorgestrel IUD does decrease bleeding, even in adolescents. Now, more recently, there is a new IUD that has come out. It's also a levonorgestrel releasing IUD, but it is smaller in size and it lasts for 3 years, and it's called the Skyla. And there's not data on whether that works, whether it decreases bleeding, but the thought is, since it's a similar mechanism to the 5-year IUD, that it will decrease bleeding in the same method. It is, and the thought is, though it's not studied compared to the Mirena, that it has, because of its size, improved ease of insertion, decreased insertional pain, and decreased rates of amenorrhea. And so it's a lot, and it is less crampy going into it for an adolescent. And so we do use this quite a bit in our patients now with heavy vaginal bleeding because it is a little easier and a little more tolerable for the adolescent from a cramping point of view. And when you think about an IUD, there is about a 6 to 12% chance of expulsion in a patient who hasn't had any kids. And so with the smaller IUD, the thought is, and again the data is not out because it's new, is that expulsion rate will be less because the IUD is smaller. But it is lasts for only 3 years versus 5 years. So in summary, what's different about the adolescent with heavy vaginal bleeding? Well, they present early. Their most common cause is anovulation. They're more likely to have a pathologic bleeding disorder. Treatments are usually medical in nature, but provide contraception if they need it, and surgery is the last resort. You know, at the end of the day, there is not a perfect way to treat an adolescent with heavy bleeding. It needs to be individualized, and it needs to be based on the family and their values and the patient and compliance. But the key is to individualize it. You need to know all the options that work in adolescence and how to frame them and set them up and help them understand the side effects that they may that they may feel, so that they have the best compliance and best effectiveness that you can have. You want to see them more regularly, and you want to taper slower. Thanks. I can take questions if you guys want. Oh. I just told you all that. Question?
So, quick question. What's your approach with adolescents whose parents don't want them on birth control because of potentially having sexual activity or increasing risky behavior? What's kind of your approach? Because recently we had a patient, we actually had 3 sisters, and their mom was like adamantly against it only because she's afraid they become sexually active.
Yeah, you know, I do talk to them a little bit about data, you know, and so I talk to them. I don't know if this patient came in for a bleeding issue. Yeah, and so I do talk to them a little bit about the data. The data does show clearly that kids who are going to have intercourse are going to have intercourse. And no mom wants to hear that, but and that if you put a patient on pills, if she was not going to have intercourse, she's still not going to have intercourse. And if she was planning on it, she was planning on it anyway. So the data is pretty clear about that. But moms don't really love to hear that, to be honest. And so I do talk to them about how, hey, I'm not here to affect family values. So we can put her on a progesterone-only option. It's going to take longer for that bleeding to stop. And if we're here to control heavy vaginal bleeding, and that's what we're here for, then perhaps we may want to consider this other option. And if they say no, that's fine. They say no. You know what I mean? But and the other thing that I do a lot, especially in those particular type of families, I talk to them about how, I give them the progesterone and the estrogen options, and I talk to them about how these are hormone pills, and it's, you know, some people might call them birth control pills, but in your case, it's not a birth control pill. It's really just a pill to help. I talk to them about how it's like the drill sergeant in front of a marching band, you know, and that their hormones are all over the bleachers and they're doing whatever they want, and I need someone to help them be in a row and raise their right leg and raise their left leg. You know, they seem to get that. But at the end of the day, like, I kind of talk to them about how it's really not for use of contraception in your case, you know. And some moms will even say to me, hey, I don't want you to even use that word in front of my daughter, and then I don't. You know, I say, hey, it's a hormone pill, and this is what it's going to do for you, and so we can get around it from that point of view as well. Sorry, did you have a question?
Yeah. So sometimes patients come in and they might have gotten blood before you get a chance to do a von Willebrand screen on them. Mm-hmm. How long do you need to wait before you order that initial screen or even a repeat screen after a transfusion?
You know, I talked to the hematologist about this, and the data seems to be a little bit all over the place, but they tend to say 6 to 12 weeks is what they tell me. They say wait 6 to 12 weeks before you test again.
And as far as finickiness of the test, if the child's actually ill or has a cold, are you not to do it then? You're to do it, you wait, and because I was told by an oncologist once that, well, if the kid has a cold, don't draw it, it'll be abnormal.
That's what I was told too, and you know, I think, you know, I think we could wait, but like if I have a non-compliant person that's not going to come back, I usually would draw it again. I would draw it anyway, and then I'll draw it again in 6 to 12. And I tell them that. I'm like, hey, I may have to draw it again because she's ill. you know, but so it may be a little bit abnormal, but let's try, you know, since you're here. So.
And then you had mentioned something about add back estrogen with either the long-acting hormonal, so with the LARCs, the progesterone only, or even with Depo. How long do you leave them on estrogen? Like how long of a course, or is it variable? I don't know that I've seen any data.
So, you know, I agree, there's not much data on how long to keep them on for. And so I tend to tell them, okay, so if they come in, it's like their first month of sort of a longer acting progesterone option. And, you know, I know the data is like 3 to 6 months. So I tell them, hey, let's try it and we'll stop at 6 months and we'll see what happens. You know, and then at 6 months, if it's still irregular, you know, and it's usually because the lining of your uterus is too thin, you know, you guys know that. And so then we'll just add it back again. We'll just keep going. And I just tell them, and then I usually have them stop every 3 months or so and just try, yeah, and daily. And the nice thing about it though is that they already have a progesterone option on board. So even if they forget their estrogen, if they start spotting, then we know, right? You know, because often they'll forget a day here or there, you know what I mean? And if they don't stop spotting, and then they usually get a little braver and they just stop taking it, you know? And if they do start spotting, then they're like, oh, I better take my pill, you know, or put my patch back on. So. Yes?
What do you use for that personally? What do you use?
I use either the estradiol pill, mostly because that's the one that's covered by Medicaid, you know what I mean? 1 or 2 milligrams. If they're not having too much, I usually start them at 1 milligram once a day, and then I tell them if it's better but not resolved, you can go up to 2 milligrams a day. But I like the patch a lot just because you don't have to think about it as much. But you know, teens are a little funny because you always have to put the patch somewhere where you can't see it. And so they like to put it a lot of times right here, and it keeps falling off because they pull their jeans up and down, and you know what I mean? So patches sometimes are not as great for teenagers, you know, even though the risk of thrombosis is considered less with patches, so that's a consideration. But sometimes they're not as good about it. So I kind of talk to them about it. I'm like, you're going to wear your patch, you know, so if it's summertime, it's a little harder, you know what I mean? So I kind of talk to them about what they prefer.
How do you treat the side effects of the high-dose estrogen when you've got somebody on a step-down, 4 pills for 4 days, 50 milligram tablets? I mean, that's a lot of headaches, that's a lot of nausea.
Yeah.
You tell them to go to school and suck it up, or?
I love when the kids go to school, so I do some of that. But I actually so I tell them that they might have headaches, and I tell them they're going to be moody. And I can't, you know, headaches is, you know, Tylenol. But what I do is I always give them Zofran an hour before they take their pill. So, or you know, if the regimen allows for that, you know, so 8 hours, you have to take Zofran every 8 hours, you know, so you have to work around if you're taking it 4 times a day. But I try and give them Zofran and keep it on board. And usually you know that because they'll have even with the IV Premarin, I'll give them Zofran an hour beforehand, just to limit that nausea.
Do you have them take all the pills at once, or you take it 4 times during the day?
I take them 4 times during the day.
Do you think it makes a difference?
The data says it doesn't make a difference, but I think it decreases side effect. So from a bleeding profile, it shouldn't make a difference, but
Compliance, it might.
It might, yeah, you know, and so I actually usually don't do 4 pills a day. I usually go to 3 pills a day because I think it's a little bit easier. And then I tell them, do you take it right before school, right after school is done, and right before bed? And that usually seems to work, that regimen, because that's an easy way to remember it, and mom can text them or whatever to take their pill, you know what I mean?
You're not going to let them take anything during school.
Right, right. So that's why I usually don't do 4 pills a day. I usually do 3 pills a day for 3 days, and then I go to 2 pills a day for 2 weeks. And 2 pills is pretty easy because you can remember taking the morning and the night, you know what I mean? So that's usually how I do it, and I've had pretty good compliance with that. And then I can also time my Zofran accordingly every 8 hours, you know, if they need it. So.
Have any questions?
Thanks you guys so much for your time.